because they were so impressed by the bee story. They were like, "What, you caught bees all summer?"
Right.
And tagged them and ran around a landfill catching bees. I said, I ran around a landfill catching bees. And they were like,
talk about passion.
He's going to do what it takes to get it done. He'll do anything, right? And so I studied like diabetic wound healing for Johnson & Johnson.
Oh, nice.
And then I really, I got my own project. I fell in love with research, and the rest is history. I came to grad school and decided I really wanted to fix hearts.
Yeah. Welcome to Holy Shift, Biomedical Breakthrough Shaping Tomorrow. What is biomedical engineering exactly? It's about engineering solutions that improve human health, from new medical imaging tools to personalized cancer treatments. Holy Shift reveals the people, passion, and purpose powering the future of biomedical research. Welcome back. Today's guest is a researcher who wears more hats than most of us have in our closets. He's a professor of both biomedical engineering and cardiology at Georgia Tech and Emory University. He's also the associate chair for graduate studies in biomedical engineering and the director of the Children's Heart Research and Outcomes Center, also known as the HERO Center. When he's not publishing papers, inventing new technologies, or running stem cell clinical trials for kids, you might catch him literally running, playing soccer, or coaching Little League. Please welcome the heart of heart research himself, Dr. Mike Davis. Well, thanks for coming in this morning to talk about science and how important science is. I have a few questions for you. Let's dig in.
I'm excited to be here.
Awesome. Okay. So how would you explain your research from a 10,000-foot level?
From a 10,000-foot level, I'd say my research has to do with fixing hearts.
Nice.
So we can start there. We go from adult hearts, so patients who've had heart attacks, the muscle dies, and it doesn't rebuild itself like regular muscle. And so we try to make materials, make cells that rebuild that muscle and try to regain their function. But then also about 10 years ago, we realized that kids also have these problems too. And it's a little bit different from adults. They don't have heart attacks. They're born with defects, that just happen. And the best we can do for some of them is just try to plug it in and see what we can do. And we use stem cells and other materials to see if we can rebuild or rejuvenate their hearts.
Love this. Okay, so in the time, and you've been doing this research for how long?
20 years I've been here.
20 years.
Almost 19 years. 19.
Okay, so since you were 5. And what would you say, given that you've seen as maybe a big shift or something big that you've been able to experience?
I think the biggest shift has probably happened in about the last 5 to 10 years.
Okay.
With the more quantitative methods. So I know everybody talks about the big buzzwords of like AI and machine learning and things like that. And it's great to talk about it, but really what we've done in my lab and other labs over the last couple of years is really try to see how we can use big data and all of this data we're collecting to inform these trials. So can we take a drop of your blood and see, is this therapy working or not just from the drop of your blood?
Oh, wow. And how would it be done? How was it done prior to that then?
Well, for the heart, we do things like biopsy. So for transplants, they just got to go in every few months and pull out a little piece and see, do we see rejection? Whereas now we can say, let's take a couple drops of their blood and see, do we now see some of these things that we've identified as markers of the rejection?
Which I think is huge. I love this because I think this is huge. We forget how this advance and this shift in a mindset in science, how it improves the patient's quality of life. Their caregivers, the pain. I mean, I can imagine now that you're doing children, right? The pain of a biopsy and how terrifying it is to go back to the hospital and the trauma involved with that versus a drop of blood.
Yeah, it's the stress of the parents and the child. I've got kids. I couldn't imagine if they were dreading this 6-month thing where they know they're going to go in, get knocked out, and somebody's going to get a piece of their heart, and then they have to wait, weeks to see the results. And, the parents are stressed out there as well. And it's a whole lot of stress and anxiety, and that could lead to other problems as well, besides the heart.
Yeah. Not to mention the healthcare cost and healthcare utilization costs that are implied with that.
That's
Okay.
intense.
So then speaking about that, in what ways does your research impact the community? So one is we've made the quality of life of the caregivers and the children and the adults better. What are some other ways it impacts the community?
So so my lab also does outreach, and we try to inform the community as well. So we're right across the street from Druid Hills High School. We just had about 30 Druid Hills High School students come over a couple weeks ago and look around and see, what does research mean, right? How do you research these hearts? We set up little stations so they could see like, oh, here's how we measure blood flow in a heart. Here's how we can look at taking cells from a skin biopsy and turn them into cardiac cells so we can study a disease in a dish. So I'd say that the research that we're doing, it's sort of from the ground up, right? We're treating the patients, but we're also trying to inform the community about how we are treating the patients so they can all be responsible for that caregiving and that sort of scientific discovery process.
I would have loved to have seen that when I was in high school. That is so cool. I'm super envious. Okay. What might healthcare look like if this research did not exist then?
Well, I mean, we'd still be digging pieces out of people's hearts. I think what we're trying to do is there's a lot of diseases where the surgeons have done an amazing job. They can save lives, but due to the fact that these kids are born with missing pieces of their hearts or things at the wrong places, they can try to work around it. But ultimately, these kids have they have heart problems, and if you have heart problems and multiple surgeries, you probably have neural problems because you're losing oxygen to your brain every time you have these surgeries. And so it's just a whole cascade of things, right? You start with the heart, then it goes to the brain, it goes to the lungs. These kids also have liver problems as they get older because of the blood supply. So I think, by treating the whole child early on, you get to sort of head off all those things that might happen later in life.
Okay, so let's go back to your core research. Then we were talking about that, and I was thinking about this impact. It's so important for us to understand the cascade effect of 1P. I think oftentimes we believe, oh, it's just the liver or just the kidney. Or when I used to do research in cardiovascular space with individuals with high blood pressure, trying to get them to understand, okay, that's putting pressure on every organ that you have an impact. And so I love what you were just saying. So when you go back to the work that you and your lab do then, is it, and you said stem cells. So for people who don't know what stem cells is, how would you define those?
So I would say that it's a cell in your body that can become multiple different cells. So for instance, in these babies, when they're born, they have to have surgery. What we do is we take a little tiny biopsy, a piece of their heart that they believe it or not, don't need. It's called the appendage. You just snip it off. The surgeons routinely move it so they can get better access. And we take that biopsy to our lab and we isolate stem cells from that.
Okay.
So they're really sort of heart stem cells. They can become maybe blood vessel cells or things like that. And then we can expand them. We can grow them up because that's another quality of stem cells is they grow a lot.
Yeah.
And then we can make, from these biopsy, we can make tens of millions of these cells that when these babies come back for more surgeries, we can then re-inject back into them.
Okay, and so what are some of the common surgery needs that these children have? Are they valve challenges? What is it that is a common thing that they then come to you and say, we want you to collaborate for this particular patient?
So the main disease we work on in our lab is hypoplastic left heart syndrome.
Oh, wow, that's a big word. Let's dig into that.
So hypoplastic left heart syndrome. Hypoplastic means like hypo is less growth. So their left ventricle doesn't develop.
And the left ventricle is a ventricle that is the major pump in the heart. And
the
you have
whole
to
body.
Yes.
You need it.
Yes.
And these kids are born without it. Like in the 40s and 50s, if you were born with it, you were just sent to hospice, and that was it. You could survive maybe a week.
Oh, wow.
And then they created this amazing surgeries where they basically reroute the blood supply to your right heart.
Yes. Okay.
It's called palliative surgery. So palliation because they're not actually fixing it, right?
Right. They're just making it a little better for a little period of time.
Yeah. So they can take the blood and they can now say, well, the right heart, which normally just sends blood to the lungs, we're going to send that blood to the rest of your body.
Okay.
And so these kids, they can live. They need 3 surgeries over the first few years of their life, and they can live. And they live pretty okay lives, but their survival is about 65%. So even though it only accounts for about 1 to 2% of all congenital heart defects, it accounts for about 40 to 50% of all mortality.
Wow.
So it's very, very serious. And what happens is your right heart, it's meant to supply blood to your lungs. It doesn't do a lot of work.
Right.
Right?
It doesn't have the same muscle.
It's just like the pressure has to go very, very low distances.
Right.
And now you're telling it, well, now you've got to pump blood to the whole body. And so that right ventricle will eventually, in these patients, a lot of times fail. It will start to get overtired, it works too hard, and these kids will end up on the transplant list, or they end up with liver failure because they're not returning blood fast enough to their lungs. It just gets stuck.
Yeah, what's the average age? If someone were, like back in those days, how long would these kids live there? Because I'm just imagining knowing the structure of the heart and that the left ventricle has so much muscle and pumps so much, right? And I'm thinking of these kids running and playing on the playground and trying to do these things where you need a lot of oxygen, you need a lot of energy, and I can't imagine you can get anywhere near that amount. So, like, what does that look like for these children?
So these kids have low exercise tolerance.
Yes, okay.
They have a lot of sort of intellectual disabilities because they have multiple surgeries and they go on bypass.
Yes.
And so the bypass, obviously, you're reducing the blood supply. And so they also are born with lower oxygen levels.
Okay.
That's one of the ways you can tell is their oxygen saturation in you and I would be like 99%.
Right.
Really good. For some of these kids, it's like in the 80s.
Oh, wow.
And so they don't get all the oxygen supply they need. So it's a lot of intellectual disabilities, lower IQ, cognitive dysfunction, and low exercise tolerance. So we are hoping, and with these trials, we just completed one big trial of 30 patients, and we're planning the next one for about 65 or 70 patients, where we inject these stem cells directly into their right ventricle, right into the right heart while they're getting the surgery.
Okay.
In the hopes that it will stimulate blood supply, stimulate growth, and make this tissue a little bit healthier. Also, these cells have anti-inflammatory properties.
Okay.
And so, as you know, surgery is a lot of inflammation.
Yes, absolutely.
And immune. And so these cells sort of work as an immune, they help the immune system and help the inflammatory reaction. And so that we're hoping that by giving these kids a little bit of boost when they're younger and able to repair a little bit better, that we might have better long-term outcomes.
Oh, that's amazing. That's amazing. Now, was the clinical trial in collaboration with Children's here in Atlanta? Was it across a different diverse market?
It was, yes, it was here at Children's. We had collaborators at University of Michigan that helped us enroll because, as you can imagine, this isn't like a million patients a year.
Right, right.
And at Lurie Children's, it was funded by the Marcus Foundation here.
Yes.
Bernie Marcus.
Nice, nice. But when it's your child, your grandchild, your neighbor's child, then it is every child, you see. Like when you experience that yourself, the impact is so huge.
Well, and the one thing is also is that when you show it's safe for one disease, you can then start to extrapolate, would it be better for other diseases as well? And so
What's your hypothesis on this?
Well, we have a trial that just enrolled its first patient yesterday.
Oh, congratulations.
Thank you. It's a combined adult and pediatric trial for dilated cardiomyopathy. So this is a disease where the heart ventricle just sort of gets stretched and thin.
Okay.
This can happen in adults for a heart attack or just heart failure. It can happen in kids that get myocarditis, which is a viral infection of the heart. Just they can have a genetic syndrome that makes their heart wall just get thin. And so we've been injecting these cells intravenous to see if we can get boost of function to their hearts.
Wow, that is amazing. Okay, you mentioned the Marcus Foundation. Let's talk a little bit about the funding for your research. Where does that funding come from?
So I've been very fortunate in my career to have good funding from the American Heart Association, the NIH, National Institutes of Health. A lot of what these trials have been funded by, though, is donor funding. So we have a really great philanthropic network at Children's and at Emory. And so the Marcus Foundation funded this project. This actually started with a woman named Katrina Sicoli, like 15 years ago, 15 years ago. She toured my lab. And I said, I think these cells that we're isolating from adults, I think the kids actually have more of them. And I think that they're more beneficial when they're younger.
Right, yeah.
And she said, well, would $25,000, $50,000 help? And I said, yeah. And so it started from that little $25,000, $50,000 donation where we can then test these cells, isolate them to see how they work, to what ended up being a $4 million clinical trial grant from the Marcus Foundation.
One of the things that I think is so valuable about this and hearing your story is that so many of us, if we're not in research, we see like ideas in isolation, or we may see a paper that publishes, but we don't actually see the long-term benefit and the impact that you have. Can you talk about, one, what made you decide to become passionate about this? Why did you decide to become a biomedical engineer and drive this type of research? And do you have any stories that you can speak of where it's really impacted your life?
Well, growing up, my grandfather was a doctor, and we had lots of little things around the house. I always had a chemistry set and things like that, and it always interested me in science. And I think when I went to college, I really wanted to go to medical school. I was taking a pre-med, and I was going to take the MCATs, and I realized I spent a summer catching bees on a landfill.
Oh, I love it. I'm a beekeeper, so tell me
So
more.
I'm allergic to bees.
Oh, no!
And so I needed a job. I wanted to live on campus and take classes over the summer, and I wanted to get more involved in science. And I said, you can go work environmental science. I was really interested in the environment.
Right.
And they said, well, you're going to catch bees on a landfill.
Oh my gosh.
And I joke, I'm not kidding.
How do you catch bees?
I'm not kidding. The landfill was called Fresh Kills.
Oh, God.
Because apparently a kill is a waterway. And so in New York City, I'm from New York, New Jersey. I went to Rutgers. And so we would drive every day to the Arthur Kill, which is where this big landfill was. They would bring these barges of trash, and they would do that. And this environmental scientist wanted to see what kind of flowers he could plant, because eventually they want to close these landfills, right? Stop putting trash on it and regrow the forest. And he wanted to see how bees, if you have a small cluster of plants versus larger, how they do it. So I would get a net, and we would catch a bee, and you would fling the net around, and you would stick in dry ice. And the bee would fall asleep from the carbon dioxide.
Right.
And then you had these little resin that they could put like a little tag on the bees. And it was harrowing because the smell was bad.
Oh, wow.
It was hot, and I was allergic to bees.
And you were how old?
19.
Okay. And you did this because this was paying for your college, or why did you do this insane thing again?
It was paying for me to stay on campus for the summer, and I decided sort of that summer that I loved research more than I loved the medical school part of it.
Okay.
And then I used that, and I got an internship at Johnson & Johnson the next year because they were so impressed by the bee story. They were like, wait, you caught bees all summer?
Right.
And tagged them and ran around a landfill catching bees? I said, I ran around a landfill catching bees. And they were like,
talk about passion.
He's going to do what it takes to get it done. He'll do anything, right? And so I studied like diabetic wound healing for Johnson & Johnson.
Oh, nice.
And then I really, I got my own project. I fell in love with research, and the rest is history. I came to grad school and decided I really wanted to fix hearts.
Yeah. Well, anyone who has the gusto to go around a landfill and catch and tag bees, I want them doing research on heart transplants and heart work. Okay, so speaking of, that was a typical day when you were 19 in college.
Yeah.
What does a typical day in your life look now? And I want to hear, a little on the personal and in the lab, or what does it look like?
Oh wow, it's changed a lot over the years, with kids and more responsibilities at work. So I get up like at 6, maybe that's early, maybe that's late, and then I try to use like 30 or 40 minutes before the kids get up to answer the flurry of emails that I missed the day before, and then I get up with the kids and eat breakfast and take. My daughter drives herself to school now, but I take my son to school down the street. And then I eventually make my way into work. It doesn't sound very exciting, but that's the morning. I used to just do research, but now I direct a big research center. So it's called the HERO Center, Heart Research.
Yeah, I want to hear more about this. So, but continue on your day first.
So I try to get to work. And then I sit down on my computer and do another 30 or 45 minutes of emails. I run the graduate program as well, and so I try to earmark a certain portion of the day to deal with, graduate-related items. We have 400, I think 500 master's and PhD students. So I try to leave at least an hour or so, and then I I like to wander through my lab and talk to my students and see what's going on.
Is your lab in the Health Science Research Building?
Yep.
In 2 or in 1?
It's in two, and I'm right down from my office. So I like to
I get to tour it sometime. Our offices are actually right beside each other. So
yeah. I like to wander in there, and I like to see what's going on and surprise them, and sometimes just talk science and see. I think the good stuff happens what they call off the books.
Yeah.
Like you don't have a planned meeting, you just kind of stop by and you're talking science.
Right.
In the spring, I sprinkle in teaching there. I teach.
What kind of classes?
So I teach a required first-year course called Integrative Core, where you learn how to integrate engineering and medicine. And so
I love
we do
this.
quantitative studies. We learn how to do computational modeling, so quantitative modeling. And say,
what is quantitative modeling for those of us who don't know?
So everything in your body has numbers, right? Like a cell, for instance, has a receptor. And that receptor, you have drugs that block it. Every time you see these commercials on TV where they're talking about some antibody or something like that, like I have my students say, how many antibodies are on a cell and how much drug can you get in your blood system? And, for this disease, how much would you need to block it? And they learn how to put numbers to things, not just sort of like, we're going to dump it. But when these drug companies, especially now these days, they're steering away from human studies, or animal studies. They want more human-based studies. We try to say, like, if a person has this type of cancer, this type of cancer has this bad receptor on it, how much drug would you need to block this effects of this bad receptor? So we try to get them to put numbers to things to understand how we apply quantitative principles to understanding medicine.
Yeah, because it's really important that you only give the amount of drug that you need to be effective, and finding that tolerance level is really complicated. And so they're learning how to start thinking of it that way. So are these students master students, PhD students?
In my class, they're PhD students.
Okay.
So this is a PhD class. It's to get them in the mindset of how do I make this into a testable hypothesis? How do I move forward with this? And so that's my day. I try to leave at 3:30, actually. I try to leave early so I can pick my kids up from school or be home.
Nice.
And then I can hang out with them. I coach my son's baseball teams.
Okay. How old is your son?
He's just turned 12.
Okay.
And then after dinner, I usually go back and do a little bit more
email. I don't know. I receive about 300 emails a day. Is that about probably what you receive as well?
Yeah, and I tell the students, like, if you really want something, I try to give them the right emails, because I said, if you email me, I'm sorry, but I get about 500-600 emails a day. I can't go through it. If you need help registering for a class, I've got a program person for the PhD program that's designed to help you.
Right. Okay, so you wake up, you do emails, you have daddy duty to deliver, then you come into the lab and you do emails again, and then you walk through your lab and you inspire the next generation, and then you prepare your classes, and then you end the day, do daddy duty again, have dinner, and then emails again.
Sometimes.
That's amazing.
I try to do it less at night, but we have grants due, we have things like that, papers due, and unfortunately grants don't understand, vacations.
Right.
And so there's been plenty of vacations where I've had to work on grants, and so evenings, are grants, and that's just a regular day where I don't have 100 other meetings. So.
Yes. Okay. So what do you think when we're talking about the impact and the research that you do and how valuable it is? I mean, it's literally changing the lives of millions upon millions of people around the world. Okay, what do you think is one thing that the average person needs to know to advocate for research like this?
I say an ounce of prevention is worth a pound of cure. And so I think they need to understand that advocating for as early intervention as possible, we know these diseases have poor long-term outcomes, but we're excited by the great short-term outcomes. I think they have to understand that just because it has a good short-term outcome doesn't mean that the long-term outcome is beneficial. So we have to really get in there and do better, earlier on, so that way we can head off these long-term problems. So for instance, in these diseases that I talked about, we know that they can survive, for the most part, their early childhood if we just do what we were normally doing. And that's great. That didn't exist 50 years ago. But we can and should be doing better now. We have the technology, we have the tools, right? We need to let us get in there and intervene early and study these diseases earlier to see how we can get in there and make an impact so that we don't have these long-term problems. So that way when they're 15 or 20, they're not needing liver transplants, heart transplants, long-term drugs. We don't want these kids to be on drugs for their whole life, right? We want to get in there early. So I think you need to advocate for, earlier intervention in these diseases, better funding for some of these orphan diseases.
Can you explain to the audience what an orphan disease is?
I mean, an orphan disease is sort of one of these one-offs. It doesn't affect a lot of people. The drug companies, you worked in valves, right? Mm-hmm. The majority of valve research is geared towards adults, right? Because there's, that's where the majority of them have the problems. But a 8-year-old with a valve disease, right, or some kind of disease that's low prevalence, doesn't exist in high numbers. This kid might have to have 5 or 6 different surgeries, drugs their whole lives, right? We want to be able to get in there earlier and maybe focus some of that research on there. And I love drug companies, but if the money is there for the 80-year-olds and the 70-year-olds, but not there for the 10-year-olds, we as scientists really have to be the ones that are advocating for this in the community.
I love this. Yeah, in the community, because the reality, as you said, any organization, any company, I've started a few companies, in order to keep it running, you need to have the revenue. And so you find typically a market that is large enough to support the revenue. However, in science and in healthcare, the orphan piece or the small populations of individuals who need treatment. And there are some people that say, oh, we don't need to focus on the small. We need to focus on the big. However, when you think about some of the most amazing people on this planet, think about that one person, that person who, I just throw out a name, like Mother Teresa or Nelson Mandela or someone like that, right? But that was one individual. And every one individual can make a huge impact on the world. And they all deserve the opportunity to live their best life. And that's what you're providing the earlier you do this research in science.
Everyone has value. And, that's not to say that drug companies don't value it. But, we did a trial in 30 to 40 kids, and it cost $4 million. And that was cheap. We subsidized a lot of that. It costs a lot of money. And so I'm not blaming any drug companies.
For someone who doesn't understand that, how does $5 million or $4 million come up? What types of expenses that for people that might think, wow, that's just an absurd amount of money and don't understand how that really adds up quickly? Yeah,
I mean, we do the MRIs. They have a couple MRIs that cost money with anesthesia. Anesthesia costs money. When you isolate the cells from a patient, it has to go a lot of quality control. You have to pay the people doing the quality control. Those tests, these are clinical grade tests, so they have to be done a certain way. That is it's not like being done in my lab. It has to be done in a certified laboratory that's inspected, semi-annually by the FDA, that gets their machines certified all the time, right? When you're running a flow, for example, that's to look at the quality of these cells. If your machine isn't calibrated properly, it can screw it up. And if you want it clinical grade, that machine's got to be tested, calibrated repeatedly, inspected. Those things all add up and cost a lot of money over time.
And yet, when it translates into the population, when it's no longer in a clinical trial, then a lot, you're not having to do the MRIs, you're not having to do as much of that validation component of it. It can actually make, because when I originally thought $4 million, it seems like a lot. However, let's backtrack. If we're treating these patients early on, they're having that early treatment, the millions upon millions of dollars for each patient throughout the rest of their life that you're saving just based off of that. And that's huge.
So for instance, one of the big findings of our study, which I hope to be, we've just done our second revision, hopefully it's finally accepted, was a massive decrease in hospitalization and cardiac complications in this population. And so that, like you said, that's less dollars being spent by the hospital systems, less by the insurance, less by their parents. So that is a cost savings eventually, right? Even though it costs money. So I think, we have to put these things into perspective and realize that it's really expensive, and we need everybody to chip in for it.
I love this. I love this. And I am just envisioning more children playing on the jungle gym than could be before.
It's, when we first did the study, I was nervous because, here's your home science and there's a kid on the table, operating room, a little, 6-month-old that's about to get an injection. And I was holding my breath like, please don't do too bad. Please be okay, all that stuff. And then, you're picturing it and then you see the results and you're like, well, these kids actually, they were in the hospital as much, right? They were released from the hospital sooner. Things got better for them and their families, and it makes you feel really good and want to do it more and see like, well, what else can we do? What else can we do this? And so I'll say, I know we're probably running low on time, but I'll say the biggest reason I got involved in kids is because I was doing this work for adults in stem cells. And one of the ICU doctors, they were needing a leader for this heart research program. He said, let's walk through the ICU. And he gave me a tour of the ICU, and he showed me all the beds. Here's this kid here for this, here's that. And we can treat it, but we don't have the best for it. And, they're developing, all these great drugs for adult heart failure.
Right.
But, these kids have heart failure and the same drugs don't work.
Right.
Kids aren't tiny adults. Yeah. We need things that are specific for kids. And that's why I got more involved in the pediatric stuff.
Well, this conversation has been amazing. Thank you. I have like chills. Thank you for everything that you're doing. We're really grateful.
Thank you for having me.
Absolutely. That's it for this episode of Holy Shift, Biomedical Breakthroughs Shaping Tomorrow. If today's conversation sparked your curiosity, pass it along to someone eager to explore the power of research to change lives. As a reminder, the opinions expressed in this podcast are those of the host and guest and do not represent those of any organization mentioned. Be sure to follow or subscribe wherever you get your podcasts so you never miss an episode. To learn more about the research featured on this show, visit bme.gatech.edu or check the show notes for links and resources. Thanks for listening, and remember, behind every innovation is a purpose, a person, and a powerful story.